The hard palate sweep, a multiplanar 2D sonographic method for the prenatal detection of cleft palate. A cleft palate, with or without a cleft lip, occurs in about 1 in 1,600 pregnancies. Cleft palate has major impact on patients' physical and mental health, including swallowing problems, impaired facial growth, dental problems, hearing disorders, speech problems, and disturbed psychosocial well-being. Successful treatment requires a multidisciplinary dedicated team to address the numerous adverse health effects. Evidence shows that initial management has profound influence on the complexity and duration of treatment and on the final outcome. Prenatal diagnosis offers several advantages: genetic investigation to rule out associated syndromes, prenatal counseling for improved psychological preparedness, and delivering at a center experienced in cleft palate repair. Despite extensive research and numerous 2D and 3D methods for prenatally diagnosing cleft palate, prenatal detection remains low. Imaging the fetal palate is challenging. This is due to acoustic shadows cast by the surrounding bony skull, which obscure the fetal palate on ultrasound. The aims of this study were to evaluate and describe the hard palate sweep, a 2D ultrasound method for detecting fetal cleft palate, and to assess the performance of this method in confirming an intact palate and detecting cleft palate. This was a prospective cross-sectional study performed between 2018 and 2022 in patients referred for a routine or targeted anomaly scan between 13 and 40 weeks of gestation. The presence or absence of a cleft palate was determined using the hard palate sweep, a method that enables demonstrating the entire hard palate, which is usually obscured. Postnatal palatal integrity was confirmed. The bony palate is composed of the alveolar ridge, lodging the teeth anteriorly, and the hard palate posteriorly. From an embryological perspective, the alveolar ridge develops together with the upper lip and is located anteriorly to the incisive foramen. The hard palate is located posterior to the incisive foramen and is formed separately by 4 bones. The right and left palatine process of the maxillary bones form the anterior 2/3 of the hard palate, and the right and left palatine bones form the posterior third of the hard palate. In this way, 2 sutures are formed, the median palatine suture and the transverse palatine suture. The union of the 2 palatine bones in the posterior midline edge forms a projecting process termed the posterior nasal spine. At the posterior edge of the hard palate, the palatine bones articulate bilaterally with the sphenoid bone. The vomer bone, which forms the base of the nose, is a midline structure positioned just above the hard palate and is therefore obscured by the bony hard palate. Only its most posterior aspect can be seen. A supine-lying fetus is a prerequisite for the hard palate sweep. Lateral or prone position are not suitable. Begin by scanning the supine fetus in the sagittal plane. Focus on the fetal profile. As the fetal profile is clearly seen, move your probe to acquire the head in extended position. Once the fetal profile is imaged in extended head position, rotate the probe 90 degrees to acquire an axial view of the fetal face with the orbits facing your probe. At this specific angle, the ultrasound beam can travel undisturbed towards the bony palate, avoiding bony shadow artifacts. The sweep commences once the maxillary alveolus is identified anteriorly. By gently angling the probe, the entire hard palate is slowly scanned, reaching its posterior-most aspect where the palatine bones articulate bilaterally with the sphenoid bone. At this plane, the posterior nasal spine is occasionally demonstrated. To confirm an intact palate, the sonographic appearance of the hard palate sweep will demonstrate a continuously uninterrupted echogenic solid line. Any disruption of the echogenic line will confirm a cleft palate. Isolated clefts of the hard palate involve only the hard palate and not the alveolus. These clefts will appear as an intact alveolus with a defect interrupting the echogenic line of the hard palate. They form at the posterior edge of the palate and progress anteriorly. In bilateral clefts of the hard palate, both sides of the hard palate are affected, revealing the obscured vomer bone seen as a midline, thin echogenic line with fluid on both sides. Included were 676 patients scanned between 13 and 40 weeks of gestation. The median BMI was 22.5, with 26.8% of patients having a BMI of 25 and above. Prenatally, 21 cleft palates were detected, 10 of which were isolated, having an intact lip. The hard palate sweep displayed good performance. Excluded were 13 cases prenatally determined to have a cleft palate which lacked post-mortem autopsy, leaving 663 patients for analysis. All 6 prenatally determined to have a cleft palate were confirmed postnatally. Of the 657 cases determined prenatally as intact palate, 2 were found to have a cleft palate, and 655 were confirmed to be normal, rendering a sensitivity of 75%, specificity and positive predictive value of 100%, and a negative predictive value of 99.7%. Finally, there was complete agreement between operator A and operator B regarding palatal integrity in the 30 cases assessed. To conclude, the hard palate can be demonstrated routinely by ultrasound throughout pregnancy. The hard palate sweep is feasible and highly effective in prenatally diagnosing cleft palate and confirming an intact palate.